This is Abraham Heimbach, and today I will be presenting the pelvic case study number 1. We have a 56-year-old female patient presenting to the OBGYN. She is postmenopausal and is complaining of vaginal bleeding, especially noticeable during sex. Her clinical history includes that she's been a smoker for all of her adult life. 10 years ago, she tested HPV positive in a pap smear, and she's had 3 sexual partners within those 10 years. She tells her doctor that it hurts during sex and she bleeds, so she's limited her sexual intercourse. Upon physical examination, her uterus is noticeably anteverted and anteflexed. There are no abnormal masses upon inspection. Here we can see the cervix, specifically the external os. Relevant anatomical structures to this case include the uterus, which is, in our patient, anteverted and anteflexed. Anteversion is when the uterus is hanging down a little more, pushing on top of the urinary bladder more so than a normal uterus. And anteflexion is when the fundus of the uterus, the top part, is pulled down further into the bladder area, making an arched back look to the uterus. The fundus of the uterus is the superiormost part of the organ, like the top of the uterus. The body of the uterus is the main portion located between the cervix and the fundus, and it has its own cavity called the cavity of the body, or sometimes the womb. The body has 2 different linings, the endometrium, sometimes referred to as the uterine lining, and the myometrium. The endometrium is the portion for attachment of embryos during pregnancy, and it's also shed during menstruation, yet we shouldn't see that in our patient because she has already undergone menopause. The myometrium is the portion more superficial to the endometrium, where the uterine muscles lie. These muscles will cause the contractions during labor. They will cause the cervix to stay closed during gestation, and they will also open the cervix during labor. They also are the cause of labor. They can help cause the expulsion of the child into the vaginal canal during childbirth, and their relaxation causes the large belly, causes the womb to enlarge, allowing space for the child during gestation. The fallopian tubes are off to the side there, and they connect the ovaries to the uterus, allowing eggs, whether they will become fertilized in the ampulla or not, to float their way into the body of the uterus. The cervix is located in the inferior part of the uterus. It's the passageway between the vagina and the uterus and is very small. Typically, only sperm and endometrium pass through the cervix. The internal os is the orifice between the cervix and the uterus. The cavity of the cervix is between the oses, and they will allow for the passage between the vagina and the uterus. The external os is the orifice between the cervix and the vagina. This portion serves as a sample of tissue for testing our patient's cervical health. The vagina is the start of the internal portion of the female genitalia, connecting the external structures to the cervix inside. The fornix of the vagina has an anterior portion and a posterior portion. They are formed within the vagina as a natural part of the cervix protruding into the vaginal cavity. Here we have the cervix itself right in this area right here. We have the internal os, which gives way into the cavity of the body. We have the cavity of the cervix, which is just this small canal here. And we have the external os, which gives way into the vagina. And as we can see right here, these folds right here, those would be the vaginal fornix. On the left here, we see a normal, healthy cervix, and on the right, we see the picture previously shown of the patient's cervix. Here we have lots of red lesions, lots of inflamed tissue, as well as more pale portions, certainly more pale than than the healthy cervix. The external os here is not as readily apparent in our patient as the healthy cervix. A curettage sample was taken from our patient from the external os, as well as an endocervical punch biopsy. The cervical punch biopsy is a procedure that takes a tissue sample from the outside of the cervix, in this case, the patient's external os. Assisted by speculum, the cervical punch can go in and clip off some of the outer cervix. The curettage sample will also take a tissue sample, except this time it's from the inside of the uterine body, right over here. This must pass through the cervix here in order to get into the endometrium of the uterus. We can see another speculum here assisting the curette as it enters through the cervix. Human papillomavirus, or HPV for short, is an STI. It's the most common STI given at 79 million Americans and another 14 million added annually. There's 330 million Americans, and the 79 million comparing to that is 24%, and an extra 5% are added each year. That's about 4 of us in our class, and by next year, another student will have it, according to the data. There is a 2-dose vaccine available against the strains of HPV that are common to cause symptoms, yet there's still strains that don't cause any obvious symptoms. HPV can be apparently asymptomatic, with many not knowing that they even have it before it might show up in a pap smear, like our patient. If there are symptoms, it's common to have warts, genital or in other parts of the skin. But the biggest deal with HPV is cancer. HPV can make people much more susceptible to cancers, such as those of the vulva, vagina, penis, anus, and oropharynx, but the most common is cervical cancer. There are 11,000 cases of cervical cancer annually, with 90% being from HPV infection. Additionally, 200,000 cervical precancers are diagnosed every year. 4,000 deaths occur each year from cervical cancer, the majority of which are caused by HPV. On the far left is a normal cervix. Typically, it's a healthy pink color. Next to it is early stage 1 cervical cancer, where the external os starts to become white and sickly. Late stage 1 cervical cancer will see red lesions begin to appear on the external os, as well as a spreading of the white tissue. The last photo on the right is a stage 2 cervical cancer, where the cancer has metastasized outside of the cervix and into other areas, causing frequent bleeding. The results, diplastic cells and cancer cells were found in the curettage sample. Diplastic cells are strange, abnormally shaped cells. These aren't necessarily cancerous, yet some diplastic cells will become cancerous at a later date. The cancerous cells are the ones that grow uncontrollably and very quickly. The patient has cervical cancer, but it's stage 1. It hasn't metastasized into surrounding tissues and organs yet, probably due to the absence of the abnormal masses present in the cervix. She does exhibit bleeding, but it's only from sexual encounters, and it isn't a spontaneous bleed, as is normal with stage 2 cervical cancer. We see plenty of lesions, though, and off-color tissue surrounding the external os, but I don't believe it's reached the final stage. If the patient was diagnosed much earlier, we could have expected a good prognosis, 92% survival rate in the first 5 years. Sadly, our patient, we did not catch it so early, even though it should have been seen for her HPV history. It's not quite as late as stage 2 cervical cancer, yet she has an added comorbidity of smoking. I'd probably place her at 60 to 65% chance of survival in the next 5 years. We have surgical options, the most popular being hysterectomies and trachelectomies. The hysterectomies will take out anywhere from the uterus and the cervix to everything, including both ovaries and half of the vagina. The trachelectomy will take out only the cervix, namely the vaginal fornix, cavity of the cervix, and the external os, leaving the vagina to create a wall with the internal os that's being held together by a band or stitch. The hysterectomy would be common for drastic measures such as late-stage cervical cancer. The trachelectomy would be ideal for an early-stage cervical cancer treatment. We also have surgical alternatives. There's cryotherapy for cervical cancer, in which the tumor is frozen off from the cervix. Laser ablation is similar, where a laser can burn off the tumor from the cervix. Medicinal options fall into two fields, chemotherapies and others. Chemotherapy medications will kill fast-growing cells. They are a type of poison that can help to kill the hard-to-kill cells. And then the others, they could be like Avastin and Mavasi, which are both combination drugs for chemotherapy. They can be like Keytruda, which is an antibody medication that binds cancer cells to assist the immune system. That's what we would call a immunotherapy medication, and other medications as well. But the most potent and the best recommended option against HPV and cervical cancer would be the preventative option, the HPV vaccine. The other treatment options are only for the cancer once it's actually developed, and then it's a fight against cancer. Here, the likelihood of not only cervical cancer, but every other cancer mentioned by HPV would drop 90% if the vaccine was taken between the ages of 11 and 12. And here we have my list of references. Thank you all so much for watching my case study.